All right, thank you. And let me add my thanks, Dr. Adamson, for that great presentation, and also to all of our participants for the great and thoughtful questions. It just occurs to me that, right, as you know, everyone gets so uber subspecialized. Orthopedic surgeons only operate on the, left pinky finger. It's so helpful to have people who are constantly thinking about the state of the art of all these things and have an ability to have dialogue with them. So this is terrific. So we're now going to move along and talk about two topics. We're going to be talking about chlamydia and management updates, similarly as we did with gonorrhea, and also vaccine development for a number of different STIs. And we're incredibly lucky, and I'm super excited to have Dr. Jodie Dionne here to speak to us on this topic. Dr. Dionne is Associate Professor of Medicine and Infectious Diseases at University of Alabama, Birmingham, and also Associate Professor of Obstetrics and Gynecology there. She directs the Infection in Women and Pregnancy Research Program there, and she is a global leader in clinical trials throughout all phases, looking at ways to treat and prevent sexually transmitted infections and hepatitis B in women and in the context of pregnancy. She's part of the leadership of the NIH-funded IDCRC network and also chair of the WHO PAHO Regional Validation Committee on the Elimination of Mother-to-Child Transmission of HIV, syphilis, and hepatitis B. It's an incredible privilege to have Dr. Dionne here today. Jodie, I'll hand it over to you. Thanks for being here.
Thanks, Rafi. Always happy to talk about STI. So I'm really pleased to be able to present the topic that I've been asked to cover with you today. One of them is really pretty straightforward, what the management is of chlamydia. I know many of you do this every day in your clinic. And the other is a little more cutting edge, where we're headed in the STI field for real prevention options for different types of bacterial STIs. So we'll get there in the second half. I do not have any relevant financial relationships to disclose to you. And I have 3 learning objectives. I'm hoping by the end you can describe these current chlamydia treatment recommendations from CDC, describe the pipeline for STI vaccine trials as we understand them today, and list the estimated impact of STI vaccines, even if they're not fully effective. It's a really important point, and it might be a quiz question for you at the end. So just taking the broad scheme for a minute, starting with the epidemiology, if you go back from 1984 to about 2024, chlamydia has almost had a continually inexorable rise. It was added to the National Notifiable Disease List in 1995. And I know from work I used to do in public health that we were overwhelmed by the number of chlamydia cases that we received. We only had the resources to focus on gonorrhea and syphilis in terms of partner management, but the chlamydia cases were far and away the most common reports that we got. You know the numbers of STI right now in the US is a significant problem. 1.6 million cases of chlamydia with a little bit of a decrease recently, which will take 9% decrease potentially related to doxypep availability. Those studies are ongoing, but we'll take a decline. And this important way to think about chlamydia broken down by age group and sex is one of the ways I like to think about this pathogen. The take-home points for me from this slide is seeing that females are disproportionately impacted compared to males, and that it's the younger age groups, 15 to 19, 20 to 24, who are the most impacted. But I think if you also think about it from a population level for a minute, you see this significant drop off in 35-year-olds and above in chlamydia. And you know that I know this is not because people are no longer sexually active. It implies that there's some acquired immunity. There's something that's happening at the host level where older people, when they're exposed to this pathogen, don't get infected the way younger people do. So that's just a clue for biologists and immunologists to say there may be some studies that could be done to understand what drives this type of a graph. And no matter where you are in the United States, I was pleased to hear how many international attendees we have. I could have shown you the global map as well. There is chlamydia where you're practicing medicine. We see it a lot in the Southeast. And if you overlay the map of syphilis and HIV and gonorrhea, you see these areas are infected. So impacted. We often see multiple infections at the same time. If you're not screening for this infection, which is often asymptomatic, you're missing it, which is one of the other points of this slide. If you look at CDC data, this is one of the really helpful networks that they have, the SUN network, where they have people who present to an STI clinic symptomatic or asymptomatic, and they can ask more questions than are typically reportable with the notifiable diseases to CDC. And what you see is whether you're focused on men who have sex with men, men who have sex with women only, or women, that this increased prevalence in the younger age group is consistent across all those groups. And that it is for teenagers less than 20, it is women and men who have sex with women who have the highest rates. But any behavior of the patient that you're taking care of in front of you is important to ask about, and not a reason not to screen for chlamydia, but a reason to screen for chlamydia. This is the picture that lives in my mind when I think of the missed chlamydia infection for the person that we didn't screen, didn't think of, didn't test. This is a really nice review from Harold Weisenfeld in New England Journal from 2018. And you can see in this picture what the fallopian tube should look like. And then where the, forgot what that's called, surgical device is, you can see the hydrosalpinx and the tubal occlusion, which is the reason this woman cannot become pregnant. So she had this procedure to understand the etiology of primary infertility. And at this point, short of surgery to remove the hydrosalpinx, to remove the tubal occlusion, her options to become pregnant are incredibly limited. And this is an infection that she probably acquired at 18 or 19 or 20 from a partner who is asymptomatic. She had ascension of this organism from the lower genital tract to the upper genital tract, never knew she had it. And then a decade later, no longer has active pathogen, but has these sequelae, which are really complicated to manage and to treat. A lot of these women can become pregnant through IVF, but that's an expensive option that not everyone has access to. So what are the basics? What are the CDC chlamydia CT screening guidelines, so you have them in mind? Routine screening for all females under the age of 25, that's driven by the epidemiology. Rectal chlamydia testing can be done in women if they have rectal exposure. They sort of say reported sexual behavior and shared clinical decision-making. It's good to ask all your patients who their partners are and which sites they're sexually active at, so you know where to screen. They're saying evidence is insufficient to recommend routine screening among sexually active young males. And this is really driven by cost effectiveness analyses that show that women are typically the ones who have the long-term sequelae, less so for men. So screening of men is less cost effective. You can argue many sides of this coin, and we'll leave that for another day. But the place that many of these women are getting sexual infections from is from their male partners. So in some studies, certain males screening is cost effective, or treatment is associated with it. If you're taking care of young men in adolescent clinics, correctional facilities, and STD clinics, that calculus changes and the cost effectiveness is there, so you should screen, including all MSM at least annually on the basis of sexual behavior and at their anatomic site of exposure. So we wanted to do a study, this was a few years ago at UAB, just to see what the prevalence was and what the predictors were, to figure out if we could do a better job understanding who would need repeat chlamydia testing in pregnancy. So of our 18,000 women who had a delivery and 13,000 who had a chlamydia test in our lab, 7.4% or 1,000 had a positive test. And we did this study with different models where we had an adjusted odds ratio looking at the most important predictors. And we put in race, urban residence, insurance status, and some other machine learning studies. We put in every possible risk factor you could think of for STI, more sexual behavior information, drug use, alcohol use. And you know what pans out in every single study is it is age that is the most important factor. So I just bring this up to show you, if you're taking care of young people, especially people under age 29 or under age 25, really think about incorporating this into your routine practice, because this is where the lion's share of infections are. The slide from the CDC that they want you all to have, and this was objective number 1 for learning, is the recommended regimen for chlamydia infection for adolescents and adults is now doxycycline 100 milligrams orally twice a day for 7 days. It kicked out our prior first-line regimen, this was back in 2021, of azithromycin 1 gram orally in a single dose. And the other alternative is levofloxacin 500 milligrams once a day for 7 days. And they didn't do this readily. We're in the process of updating right now the 2025 CDC STI treatment guidelines. And I can tell you the discussion takes a lot of weight, puts a lot of weight on what the frontline providers think. And the concern obviously here was 7 days of a BID regimen, sending the person home with that. You always wonder, did they finish all 7 days? It's much easier to give them one dose one time and know you've treated the infection successfully. So this was based on good clinical data showing that doxycycline had a higher efficacy, 3 to 7% higher, so small but significant compared to azithromycin single dose, and a 91% cure for rectal chlamydia and MSM. Like Paul just mentioned really nicely for gonococcal infection, we worry that chlamydia rectal infection is harder to treat. So we want to make sure that we're treating at the rectal site as well as the urogenital site. And that led to this push of putting doxycycline as first line. You can prescribe monohydrate or high plate. I would just go by what's on your formulary. There's capsules, tablets, oral suspension, and IV. The monohydrate tends to be $10 to $30. The high plate is more like $100 to $300. So sometimes cost is a reason you would pick one over the other. They're both equally effective. And you can still use azithromycin if you have significant adherence concerns for the person in front of you, or they don't have stable housing and you don't think they'll be able to keep the pills with them or finish it, or they tell you they don't want to take a 7-day regimen, you can still use azithromycin. Levofloxacin works, it's just sometimes more costly than the other options. Erythromycin is no longer an alternative because of the GI intolerance associated. Remember to tell them to abstain from sex for 7 days, and then to talk about partner therapy for their partners within the past 60 days or the last partner that they tell you about. If they're pregnant, you do a test of cure within 4 weeks. It's important to document clearance of the pathogen. I'll show you some data on that point. And if they're not pregnant, you do repeat testing for all in 3 months. And we don't call that a test of cure. It's a repeat infection. It's a repeat testing looking for recurrent infection, knowing that recurrence is so common, typically because the partner has not been treated. So with those concerns about a 7-day course, what about short course doxycycline? Do we really need 7 days? Could shorter course be as effective? No one's really looked at this, but we do have this new RCT that's being run right now. So just to tell you something that will have data soon, this is an IDCRC study where they're looking at 3 days versus 7 days, led by 2 PIs at the University of Washington, Julie Dombrowski and Christine Kosrapor, funded by DMID, with enrollments at 8 sites, US and Kenya. UAB is one of the sites we're enrolling in this trial, with results anticipated late 2026. There's 660 people to be enrolled, half male, half female, randomized 1-to-1 to doxycycline 100 milligrams POBID for 3 days or 7 days, with a primary outcome of microbiologic cure at 29 days. This was a picture just from about a week ago in Rockville of our IDCRC meeting with NIH, a really terrific network, which has assumed the responsibility for doing STI clinical trials across the US and across the globe. So it's one of the networks that's really critical to try to keep supporting in these times. So this, like many good research questions, came out of a clinical conundrum. I kept getting these calls from OBs who were saying, Dr. Dionne, my patient is pregnant and I keep treating her for chlamydia and it keeps coming back. I know she's taking it because I'm watching her take this pill, but when I test her for a cure in a month, she's positive again. So we said, how often is this happening? And you start to think, is this emerging chlamydia resistance to azithromycin, which shouldn't happen, but we want to be on the lookout for it? Is this adherence concerns? Is this related to lack of partner therapy? So more data lets you figure out what the likelihood is. And what we found out, just to go through this quickly, of the 16,000 pregnancies with chlamydia testing, we had 840 where we had documented azithromycin treatment and a repeat NAT more than 21 days after their prior. So we didn't want to pick up dead or dying organism. We know that within 7 to 14 days, that could be false positive. So of those 840 who had repeat testing, we actually had a significant number with persistent or recurrent infection. So only 78% had cleared, 14% had persistent chlamydia, persistent NAT positive, and 9% had recurrence where they cleared, but then a subsequent month had it back. And we didn't have all the information about partner therapy. We knew that they had been referred on standard recommendation, but it wasn't something that the providers were giving azithromycin to the woman to bring to her provider. So it wasn't truly EPT or expedited partner therapy, but that was really our take home. We didn't think this was evidence of emerging resistance. We knew adherence wasn't the major concern because of the single dose therapy and because of DOT in many of them. And we said, boy, we sure wish we had a better way to make EPT happen, because we think that could reduce this persistence recurrence rate closer to zero where it should be. Unfortunately, in this really nice study that was published by Emily Adhikari, this was done at the Parkland Hospital in Dallas, a pre-post design starting in 2019, where they also recognized how much chlamydia was recurring in their pregnant patients. And they said, why don't we do an EPT program where we give the woman the single dose of azithromycin to bring to her partner? This obviously requires disclosure. It requires her telling her partner that she has this infection and that he needs treatment for the infection. So challenges associated with that. They excluded women who had concomitant STI or HIV. They excluded women who were involved in a relationship and had reported domestic violence because they knew that could be a risk. And unfortunately, in the pre and post design, when they looked at these women, 419 who delivered before EPT and 471 after EPT, there was no difference in the chlamydia reinfection rates. It was 15% before, 13% after, with an odds ratio of 0.86. The populations were pretty similar, but this wasn't a randomized controlled trial, so it's not to say that this is a done deal. They did say that prescribing, giving the medicine to the woman is not the same thing as knowing that the partner took it. So their next recommendation for a study would be to bring the partner in for directly observed therapy, where you may be more likely to see an effect. So that ends the first part of the talk, talking about chlamydia treatment, where we've come, and maybe a little bit about where we're headed. But let me tell you about vaccine prevention for these STIs. I think we all like to think about HIV and STIs as a multimodal world now. We want to have a lot of options for our patients so they can pick the one that works the best for them. And because STIs are often asymptomatic, because people are exposed in between visits, not knowing that they've been exposed, it would be wonderful to have a vaccine like HPV we could give people pre-debut or before exposure that would protect them over years, over potentially a lifetime, from these incredibly common pathogens. So let me tell you about some of the rationale and the progress to date. The biggest barrier, one of them, I think, to the HIV vaccine as well, is you can develop a really good vaccine when you understand the immune response. And for many of these STIs, we don't understand the immune response, and this figure shows that really nicely. After exposure, you have a period of time, an incubation period that lasts 1 to 6 days. You have 33% of all exposures in the green path that never get infected. They stay uninfected. Do they have immunity? Is it a burden question? They were exposed to lower burden chlamydia? We don't know. 66% of all exposures have symptoms. Asymptomatic infection is much more common in women than it is in men, but some people who are asymptomatic later develop symptoms. And some people who are asymptomatic go on to the green bar at the bottom and clear their infection spontaneously. These are all clues. These natural history gives you an idea that whether it's a pathogen solution or a host solution, these are ways we can think about designing vaccines that harness the use of our own immunity to keep these infections at bay. Some of the specific challenges at the pathogen level for gonorrhea is these pathogens are really smart. They've coexisted with us for a very long time. We have data from hundreds of years ago about all these STIs being around. So that means that they are smart pathogens. There's antigenic variability of the organism. There's heterogeneous circulating strains. They change their surface expression of proteins. So even if you had protection 6 months ago, the surface protein exposed today could be different. And there is not protective immunity following natural infection. We all know patients who get infected over and over and over from these. So it's not as simple as saying you get infected, you have immunity afterwards. But remember the chlamydia data at the top, right? If chlamydia is going down after the age of 30, there may be a role for some immunity for some people, and that's one that we can delve into and explore. We don't know the correlate of protection. People have looked at lots of different examples of correlative protection. None of them have been clear. And then we haven't really had a good animal model to do these studies. There have been studies done in primates and studies done in mice, but they're not terrific examples. And lots of failed gonococcal vaccine candidates, with the feeling of the field right now that we need multiple antibody binding targets to trigger the complement activation to lead to the bactericidal response. We need a response so that as soon as a woman or a man is exposed at the genital site, at a mucosal site, that they can recognize and clear that infection before it even gets into the humoral system, gets into the bloodstream. And that's really challenging. It's challenging to clear mucosal-based infection. So coincidentally, some people in New Zealand had a wide campaign to do a meningococcal vaccination with their new meningococcal vaccine. And they saw at the same time, some curious epidemiologists, that their chlamydia rate was staying the same, but their gonococcal rate in the people who got the meningitis vaccine dropped by 30% at the population level. So they decided to follow it up and say, why is this happening? Could there be some cross protection provided by the meningococcal vaccine against gonorrhea? Neisseria comes in different flavors. And what they found was this 4C-MenB vaccine has OMV, has proteins on the surface that are the same in Neisseria meningitidis and Neisseria gonorrhea. This is maybe the most important one, this NHBA, Neisseria heparin binding antigen. And this led to clinical trials to say, why don't we look at that endpoint? Why don't we give this vaccine? And instead of focusing on meningococcal disease, let's look at gonococcal infection. So the first one that came up was already been mentioned. This is the ANRS Doxyvac trial. Jean-Michel Molina conducted this, was published in the Lancet 2024. People think of this as a doxypep trial because the doxypep was incredibly successful, but it was a 2x2 factorial design. They did also look at the impact of vaccination with this meningococcal vaccine, the 4C-MenB, focusing on MSM above the age of 18, HIV negative participants in a PrEP trial who had STI in the past 12 months, randomized 1-to-1 for vaccination dosed at 0 and 60 days. We're just going to focus on the vaccine part of this study. The participant characteristics, median age about 40. They had 10 partners in the past 3 months, so you have to decide if that's characteristic of your patient population or not. Their condom use with anal sex was about 30%. Most participants had 2 STI in the past 12 months, and 68% had history of gonorrhea in the past 12 months. So this was a highly, highly exposed group. And you can ask yourself, is this a group that we think a vaccine would work better in or worse in? Who would you want to get the vaccine if it's not going to work in this group? How can we reach the target participants if it doesn't work in the most highly exposed? They had high incident STI rates at enrollment, 13% for gonorrhea, and they had to stop this trial early because it was having such an impact on incident STI rates that they didn't end up with enough power to fully assess vaccine efficacy. But if you look at the Kaplan-Meier here from 0 to 24 months, you see the adjusted hazard ratio was 0.78, with 103 events for the 4C-Men vaccine and 122 events for the unvaccinated group. Only 67% completed 12 months of follow-up because it was stopped early. You can see here I listed just the adverse events, injection site reaction mostly. And the vast majority of their infections were pharyngeal. Many fewer were, about the same were rectal, and many fewer at the urethral site. So one of the take-homes from this is maybe it didn't work at a statistically significant level at the pharynx, but maybe it could potentially have worked or have some modest efficacy at the rectal site and the urethral site. So that brings in the study MAGI, just to tell you about quickly, looking at this in a phase 2 trial, the same Bexsero vaccine in preventing gonococcal infection. This is an NIH-funded study where participants are randomized to Bexsero or placebo. This is just focusing on the Bexsero efficacy, follow-up visits, and the target enrollment was 2,200 to be able to reach at least 202 incident gonococcal infections. And the primary outcome is to look at the efficacy of this vaccine in urogenital and or anorectal. You see, we don't have pharyngeal listed as a primary outcome for this study. Slightly different study population, slightly different study aims. The study sites are international in scope, many participants from Malawi and from Thailand. And we ended up with 2,600 people enrolled, 75% male, median age 31. And we are following patients now through February 2026. So by the end of next year, we hope to have data to share with you all about whether or not this 2-dose meningococcal vaccine had any impact on reducing the rate of gonorrhea at the anorectal site and the urogenital site in women and men. The UK, in the absence of additional clinical trial data, went ahead and said, you know, we have this potentially partially protective vaccine, and we think it makes sense to offer it. We don't want to wait for more clinical trials data. We are bothered by these persistently high rates of gonorrhea in our community. So they did these models to try to see what the impact would be of a partially protective gonococcal vaccine. So the studies have shown so far this cross protection may lead to a 30% protection, not a 90%, not what we usually think of as what we need to have for vaccine efficacy. So look first on the left-hand side of this figure. If you assume that all people were willing to take this 30% effective vaccine, this is the decrease in thousands of diagnoses per year. In red, if you only vaccinate the people who had a positive GC-NAT, and in blue, if you vaccinate all the people who have an STI risk factor. And this is assuming not only efficacy of 26% and 40%, so significant public health benefit with a, you could call minimally effective vaccine. The duration of protection they assumed was also quite short. The duration of protection was 1.5 to 3 years, which is what some of the studies are suggesting. So the point I want to make to you here, if you look at the right, even assuming that they won't all want to be vaccinated, but just some will, you can bring down the rate of gonorrhea by 10, 15,000 in this population of 30,000 significantly with a vaccine that is not 80, 90, 100% effective. So that's a really important take-home point to remember. Ultimately, vaccines only work for people who accept them. I think we all recognize we're in a world of more and more vaccine hesitancy. Since COVID, patients have more questions about vaccine. Why should I take it? Am I really at risk? But this study of 713 men and gender diverse individuals who have sex with men in this RISH 2023 survey, 64% overall said they would be willing to take a vaccine that could protect them in the future against getting gonorrhea. And if you look at the younger age groups, they're actually more likely, 16 to 29 and 30 to 34, 69 and 71% would accept, compared to the older 45 and older 58% acceptance. So obviously saying you would accept a vaccine in a study and actually accepting the vaccine are two different things. But I think this sheds light about the interest in the community of having more options to protect themselves, protect their partners against these STIs. So I've talked with you about Bexsero, but there are 6 or 7 ongoing phase 2, 3, 4 trials, 2 and 3 trials looking at different formulations of gonococcal vaccines. So stay tuned. It's a very rapidly evolving field. And ultimately, even if there's partial protection provided by Bexsero or these other products, we recognize we need to build an even better gonococcal vaccine, something that's focused on the gonococcal proteins, something that we could give people before sexual debut that would last for a very long time, that would give high levels of protection at all exposed mucosal areas. So this is probably a lifetime amount of work, maybe 2 lifetimes of work, but it's really great to see funding and research focused on these questions to start to have more options for our patients. So stay tuned for more results from MAGI. Quickly, just to tell you where the chlamydia field is a little bit earlier, they're in phase 1 development of some of these vaccine products for chlamydia vaccines, but I think there's also more funding looking at this. And as of last month, the most exciting hot off the press data I can share with you is there's a new mRNA chlamydia vaccine that Sanofi just got fast track status for. Everyone is trying to design new mRNA vaccines for old pathogens, and many people are having success across a lot of different organisms. So this is super to see. We'll stay tuned to see how this one works. And then we also have studies looking at syphilis vaccine development, which is also challenging. Like gonorrhea, T. pallidum excels at evading the immune system, antigenic variability. We have a rabbit model that is not ideal. We have no known correlate of protection. Again, a problem, as I mentioned, not a lot of understanding about the pathogenesis of the fetal infection and the passage across the placenta. We would need to have full protection before primary disease, before the wide dissemination we know happens early in syphilis, broad protection against different strains, and immunity induced for everyone around the world, including in pregnancy. These outer membrane proteins are the clues that the biologist can use to start to use bioinformatics to figure out what the right target would be for a vaccine. So just to give you a sense of the world and the rapid evolution, I think that we will have more and more products to test for gonorrhea, chlamydia, and syphilis in the coming decade, and that's really excellent. We hope we don't backslide on that at all. So in conclusion, chlamydia is the most common reportable STI in the US. 1.6 million cases. The treatment guidelines, so you have them cemented in your brain, doxycycline, 100 milligrams PO, BID for 7 days. Recent ecologic and lab data show this evidence of potential cross-protection for a meningococcal vaccine against gonorrhea, with the studies coming out soon. We need more studies in the future with adolescents and young adults, pregnant women, people with HIV. We have to make sure that our vaccine trials and treatment trials are inclusive of the people who are at highest risk of STI. And I think that the early stage vaccine trials are quite promising. With that, I will stop, and I think I have some time to take your questions. Thanks.
Thanks, Jodie. That was really phenomenal. It's so great to hear all of this progress, and really congratulations on the Magi success of enrolling such a broad and diverse population. I think we're all looking forward to those trial results. I'm sure you are too, after all that work. So congratulations on that. We have a couple of questions that our live audience have put in that we'll start with, and then actually some people actually put in some pre-questions, so we'll get to those also. So this is really great. So we have a couple of questions about pharyngeal chlamydia, and questions of, is it really a thing? Should we be worried about it? How often is it symptomatic, and are there sequelae?
Huge debate in the world. So this is a manifestation of our testing practice. We do think that pharyngeal gonorrhea is important in terms of not only potential disease and transmissibility, but as a place where the organism can pick up some of the resistance capabilities at that site. We know it's critical. Chlamydia, it's not so clear. I think that the CDC would say that the evidence of disease on the individual level and the evidence of transmissibility, the data is not fully convincing. So if you look at the guidelines, they don't even say that you have to screen the pharynx for chlamydia. But since everybody uses platforms that use NAT testing that give you gonorrhea and chlamydia at the same time, we all are facing these results of responding to a chlamydia positive NAT at the pharyngeal site, not wanting to ignore it. We don't want to ignore any pathogen. It's not part of normal human flora. So we treat it, but I think that this is one of those things where if we didn't have that paired test, I'm not sure we would be doing harm to the participant or to their sexual partners. But this is the type of thing at STI meetings that people debate vociferously. There's some people who think strongly that the data is lacking, not that there isn't a problem in transmissibility or disease. So hot topic.
No, that's really great, because I think we all struggle with that, and it's great to hear that nobody knows the answer. So that's terrific.
I mean, I think just the one other thing to bring up for vaccine is if you think about it being maybe more like a colonizer, right? So it's attached to some of the epithelial cells, but you're picking it up on your swab, but it's not causing inflammation. It's not going to the lower cellular level and the tissue level. That's where you really start to worry, because if you don't have vaccine protection against that, but it's not an invasion and it's not causing sequelae, is that a fair outcome for the studies? I think is the downstream question of that. So
just following up on that, is anybody looking at sort of pathogenesis sort of with biopsies and things like that, or
yeah,
no?
no, your mind is exactly the way the clinical trials people go who design these. So I know that Kim Rakowski, for example, at Emory's had discussions bringing ENT onto the team so that when they're doing sampling, it's not just a surface sampling, but you can imagine tonsillar biopsies and pharyngeal biopsies are not a small, simple thing. They bleed a lot. Participants don't love the idea. They're not bothered by the infection. So sure would be really nice to know, really hard to design the study and get it done to answer the question.
Yeah, absolutely. Although we biopsy a lot of things that people would probably not enjoy being biopsied.
That's true, but I think rectal biopsies are much more easily tolerated in these trials, and cervical biopsies. I think for me, the pharynx is sort of a different bar, but maybe we just need to be braver.
Love it. Thank you, Jodie. So we have a question, particularly around chlamydia treatment with azithromycin. And, if there are questions about inadequacy of 1 gram of azithromycin, has anybody looked at when 2 grams were used in the old days for GC, if that was differentially effective for chlamydia, and have we tossed out azithromycin prematurely, particularly with its advantage of DOT and single dose?
Yeah, I think it's a good question. I don't think that we have efficacy. There's certainly nothing comparing 1 gram to 2 grams to say that 2 grams would be better. One of our old standbys in STI treatment is just to double the dose and see if it works. And I think it has bought us time for gonorrhea. But for chlamydia, the people who study azithromycin and chlamydia, they really still maintain it's incredibly effective. It's not as if there's new resistance genes that chlamydia has acquired against azithromycin. So it's not as much a need to increase the dose as the alternative option with a slightly higher treatment efficacy rate. I think slightly is important. 3 to 7% at the end of the day, when you have data, there are studies showing 100% efficacy of azithromycin, azithromycin for chlamydia. So it's you don't have to feel bad or any kind of guilt if you're giving your patient azithromycin because it's a better drug for them. It still has very high efficacy.
I think that's a really important point, and thank you for saying that, because I think sometimes, depending on who's in front of you, right, the DOT-ness, if that's a word, of it is going to outweigh that small differential efficacy. Yeah, so
100%.
thank you. That's really great. So you said concerns about doxycycline in pregnancy. I think we talk about teeth staining, and I think we're all sort of thinking, is it bone? Is it liver? What is it? So what pushes you to say, I'd rather not? Is it those issues, or are there other things that we're not thinking of?
I think this is a really good example of, we all have this thing we learned in medical school about teeth staining, and it stays with us forever, and it makes us take something off that could be an incredibly effective option. So within the OB world and even the pediatric world, there's a lot of interest in doing these trials, whether it's rickettsial disease or others, where doxy is the best option, and doing more follow-up safety studies of the children and of fetuses exposed in pregnancy to show that this concern about tooth discoloration has been way overblown for a very long time. Unfortunately, having tried to propose these studies in the past, when the IRB looks at it and the FDA looks at it, that perception of risk, once it's there, is really hard to get rid of. And if you don't have the data to show safety, they continue to point to these old studies with not great not the best study design. So I think you're going to see progress. In my mind, I think it's going to have to be the people doing the rickettsial studies, the Lyme disease studies, showing the safety outcomes, and then people will feel more comfortable starting to design at least small safety trials in pregnancy for doxy, but I think it's coming. Oh, you're frozen. Can you hear me?
Oh, sorry. My internet just decided it was the perfect time to reset. I'm back.
No problem. I see you well.
Okay, great. Love technology. Okay, minor clarification about the recommendations for abstaining for 7 days in the context of treatment of diagnosed chlamydia. 7 days after completing treatment, or after diagnosis and inception of treatment?
Yeah, I mean, so it's easy with azithromycin because it was the same thing. With doxycycline, you think about the doxycycline within 2 to 3 days clearing most of the pathogen that's there. I don't usually tell the patient that. I'll usually say 7 days from when it's done, knowing that in my mind, it probably will be sooner. And this isn't something like herpes where you know that the transmission can occur even with a condom on. If they use a condom, that's going to reduce that rate significantly. So you just give patients those options and let them decide. People typically don't want to get reinfected. So when you tell them these are the ways to prevent reinfection, I think they tend to listen to the advice we're giving them.
No, that's great. And thanks for clarifying that. Do you have thoughts on differential efficacy tolerability in your practice with the different formulations of doxycycline, the Hyclate, the 200 milligram tablet when you're using it as doxy pep,
Yeah.
how do you think about that when the options come up? Some are more expensive, some are less available. How do you triage it?
Yeah, so the question comes up all the time because you try to order it and then you have to pick one and everyone's like, I don't even know what the difference is between these two. So the Hyclate is more expensive. That's the one that I said between $100 and $300. I just looked it up this morning on GoodRx. So that's the GoodRx price. But if your patient has access to it or you have it on formulary, it's water soluble and it's covered with the coating where it releases further down the GI tract, which the pharmaceutical company will say is a strength. I'm not really sure that that's truly a strength. I think that the studies have been done looking at efficacy with both, and the efficacy is equal. So I tend to do what's most accessible for my patient. If there's someone who doesn't have insurance or is paying out of pocket, I definitely do monohydrate. If they have a pharmacy that has a formulary preference, either one's totally fine. That's how I think about it. I don't know. I mean, you tell me, Rafi. I have not heard the concern about the poor tolerability with the 200 milligrams doxypep. My patients who are on it have not complained at all.
Yeah, I just have a hard time finding people who can find it in a pharmacy, right? Yeah.
Yeah, true.
No, that's great. And we're almost out of time. So last two rapid fire questions.
Okay.
Are you following the UK guidelines and offering Bexsero to people that you're concerned that they might be at risk for recurrent gonorrhea?
No, because I think that we need to wait for the clinical trials to be done. And I think that if there was, we now have other things we can do about potentially reducing gonorrhea rates. The GC data is a little bit mixed, but no, I'm interested in seeing these RCTs that go to completion that are powered to answer the question, because there is always some risk associated. I don't want the patients to assume a risk until we know there's a benefit. So I would mention it to them, and if they really were asking for it, I wouldn't stop them, but I'm not doing it routinely, no.
Perfect. All right. Thank you, Jodie. That was really fantastic.
Super.
Amazing. And thank you, everyone, for the great questions and engagement. I'm
Thanks.
now going to pass it back over to Susanna to introduce our next speaker.